Today I will be discussing about immediate versus delayed implant placement and joined by Dr. Karnik Shah. So let's take a look into the PowerPoint presentation. Okay, first we're gonna discuss about immediate implant placement. So advantages of the immediate implant placements are as such. Number of surgeries are minimized, overall treatment time is shortened, width and height of alveolar bone is preserved, better implant location results in maximum function and aesthetic soft tissue support. So guidelines of the implant dentistry. I discussed the guidelines in detail in my previous lecture. I'm not going to go into the details of it. You can check that lecture out. So let's see the indications of immediate implant placement. So the indications are root fracture, trauma not affecting the alveolar bone, endodontic failures, residual root, and decay without purulence. The contraindication for immediate implant placements are as such: infected site, which is presence of abscess or purulent exudate, insufficient depth for primary stability of a fixture, width of an extraction socket is less than 3 mm, and type 3 socket. So the classification of extraction site given by Salama and Salama is on the picture on the right side. So type 1 socket is 4 or 3 wall socket, minimum resorption, sufficient bone beyond apex. Type 2 socket is bone dehiscence less than 5 mm, and type 3 socket is inadequate vertical and buccolingual bone, recession and severe bone loss of a labial bone plate, severe circumferential and angular defect. So the clinical cases that I have treated in the private practice, let's see all one by one. So case 1 is root fracture on number 12. So this is my patient. From the clinical picture and radiographical picture, as you can see, number 12 had a restoration that was fractured and the tooth was non-restorable. So extracted the tooth, and from the picture you can see the buccal plate was intact. On the palatal side there was a little bit of dehiscence. So I ended up placing the Nobel Biocare implant and took the periapical radiograph. This is how it looked on the periapical radiograph. Grafted the socket with corticocancellous bone graft, and because of the palatal dehiscence, put the cytoplast non-resorbable membrane and sutured the entire area. I waited for 4 months. After the osseointegrations, followed the prosthetic steps, and restored the crown. This is how it looked after completion of the restoration of that particular implant number 12. So case number 2 is immediate implant number 12. So the clinical picture and radiographical pictures, you can see from the periapical radiograph, number 12 area had a periapical infection, and there was the infection surrounding the apex of the particular tooth. Explain it to the patient the condition and give the patient option of root canal and immediate implant placement. Patient opted for implant placement. So extracted that tooth, cleaned the infection, and reflected the flap a little bit just to confirm the alveolar sockets. The alveolar socket or the bone was present. So clean the area again and followed the osteotomy steps and placed the implant and took the periapical radiograph. Grafted the socket with corticocancellous bone graft and sutured the entire thing. So case number 3 is endodontic failure of tooth number 4. Then on the periapical radiograph, as you can see, tooth number 4 had a root canal done and there was a fracture on the cervical area. So it was an endodontic failure. This is how it looked on the clinical slides or the clinical pictures. Atraumatic extraction done of number 4 area. Prepared the osteotomy and placed the implant. Grafted the surrounding area of the implant with corticocancellous bone graft and sutured the entire thing with cytoplast silk sutures. This is how it looked on the periapical radiograph. Next case is residual root of number 12 area. So this is the clinical picture of number 12 area. The tooth was fractured from the cervical area and it was non-restorable. Extracted the tooth, cleaned the socket, checked the alveolar socket for any dehiscence or fenestration. The socket walls were intact. Prepared the osteotomy and placed the implant. This is the final picture after the restoration of number 12 area. So literature review says that immediate implant placement, the success rate of immediate implant placement is ranging from 89% to 97%. So which is a pretty high success rate for immediate implant placement. So if you follow the guidelines and protocol for immediate implant placement, so success rate is pretty high. Now let's take a look into the delayed implant placements. Indications are as such: type 3 socket, insufficient width and depth of extraction socket for primary stability of the fixture, an infected site, that is presence of abscess or purulence exudate. Let's see the clinical cases one by one. The first case is type 3 socket. Patient had a severe infection on number 10 area. So extracted the tooth, clean the socket and open up the flap with papilla sparing incision. This is how it looked after the extraction. It was a type 3 socket. Grafted the site with corticocancellous bone graft and put a membrane, closed the entire thing with silk sutures. Waited for 4 months for the socket to heal. And the patient came back. Again I opened up the socket, opened up the flap with papilla sparing incision just to confirm the buccal cortical plate presence. Prepared the osteotomy, followed the steps and placed the implant. Because of the exposure of the threads, grafted the area and uses cytoplast membrane, sutured the entire thing with silk suture. Case number 2 is insufficient width and depth for a primary stability of the fixture number 19. Patient was in pain around number 19 area. After the careful evaluation, clinical evaluation and radiographical evaluation, came to the conclusion that number 19 had a vertical fracture. So it decided to extract. So extracted the tooth. On the right side picture, the question arises that why didn't I place the implant on the same day? Unfortunately, I don't have the CBCT slices, but patient had insufficient vertical height too. So decided to graft the site with corticocancellous bone graft, close the entire thing with cytoplast membrane with the tenting screws, waited for a couple of months. Patient came back after 4 months for the implant placement. Open up the flap and this is the ridge looked after the healing of the site. Place the implant after following the osteotomy steps, grafted the site and sutured it. The case number 3 is active infection around number 3 and number 5 area. So this is my patient. From the clinical picture you can see the patient had a long span bridge from number 2 to number 6 area. From the clinical picture and radiographical picture you can see that there was a severe infection around number 3, number 6 area. Number 2 tooth was still salvageable, so decided to save that tooth and extract number 3 and number 6 with the bridge. Extracted the tooth number 6. This is how it looked after the extraction. This is the socket. So from number 3 to number 6 area, put the bone graft and covered that entire thing with cytoplast membrane and sutured with silk suture. Waited after a month. This is how the healing looked. Again waited for 3 months for the socket to heal. Open up the site again for the osteotomy and implant placement. So place the implant number 3 and number 5. I waited a little longer to place implant number 6. This is how it looked after the placement of the implant. Sutured the entire thing. So to conclude my presentation, immediate versus delayed implant placement, treatment planning and case selection is very important. Also, we looked at the indication and contraindications of immediate and delayed implant placement and use of appropriate bone graft and a membrane and follow-up appointment cares. I hope you all liked the presentation. Now I will open up the floor for the question answers. Thank you so much. Dr. Karnik, do you have any questions with related to the presentation that I did today?
Thank you very much, Dr. Vishal, for the presentation. I think it was a good overview of when should we use immediate implant placement and when should we do delayed implant placement. Now, that being said, I have a couple of questions. First one is, could you shed some light on what kind of membranes do you use for certain situations?
Okay, so in the clinical practice, I use cytoplast resorbable and non-resorbable membrane extraction socket where I will not be able to get the primary closure. That time I use non-resorbable membrane, and if I know that I will have to open up the surgical site second time, that time I will go with the cytoplast non-resorbable membrane. The rest of the time, if I will get a primary closure, then I will use cytoplast resorbable. If I don't have to open up the surgical site again. Then I will go with the resorbable membrane.
Thank you so much for that answer. I have another follow-up question for one of the cases that you showed. For that patient where you were planning to place an implant on number 3, number 5, and number 6, what was the reason you decided to delay the placement on number 6 area?
Waited for 4 months. Patient came back. I opened up the site for the implant placement, but when I opened up the flap, I realized that the bone around number 6 area was not sufficient to place the implant. So I decided to regraft the area again. So I ended up placing implant number 3 and number 5. That's why I did not place the implant number 6. But after regrafting, I waited for 4 months and then I placed the implant number 6.
Thank you so much for those answers. I think that was a good highlight of immediate versus delayed implant placement. I really appreciate the presentation that you've been doing, and I'm sure our viewers can also appreciate that we are covering a lot of clinical tips and tricks and protocols that we do in our everyday practice. So for the viewers who are watching, if you have any questions, any concerns, any comments, please leave that in the comment section on our channel below. And please let us know in the comment section again if you want us to speak on certain topics, if you want us to give certain information or share our experience with certain things that you do in your everyday practice.
Perfect.
Thank you so much.
Any other questions do you have for me?
No, that is it.
All right. Thank you so much.